This is Patrice Wendling at the American Heart Association, speaking with Dr. Nitish Chowdhury, who just presented results for the FREEE trial. Doctor, you missed your primary endpoint, but you did find some encouraging results. Could you describe those, please?
Sure. So what we did was eliminate copayments for post-MI medications, ACE inhibitors, angiotensin receptor blockers, beta blockers, statins, and doing so increased adherence. This also reduced rates of major vascular events, which was one of our pre-specified secondary outcomes. Looking a little more carefully at what the results show, we see that all of the non-discretionary hospital-based events like MI, unstable angina, stroke, heart failure were reduced, but revascularization wasn't. So this was why the primary outcome showed a trend towards significance, but certainly did not meet statistical significance.
Despite getting free meds, adherence was still pretty low. What can be done there?
Yeah, this is a very tough problem. Adherence was terrible, and even in the free drugs group. So we did improve adherence, and it seems that this is still an attractive strategy, but it's clearly not going to fix the problem for everybody. And the reason is that adherence is a multifaceted problem, and everyone has not only one reason, but multiple reasons, and everyone's reasons are different. And so we need to go one by one through the other causes of non-adherence. And I'd like to see a series of these simple, scalable interventions like the one we evaluated. So thinking about forgetfulness, how can we remind patients? Can we use text messaging, for example? How can we address issues of knowledge and attitudes? So for example, patients may not know that their statin is not going to specifically make them feel better. You can't feel cholesterol going down. Or how can we address complexities? So some patients have to take multiple medications multiple times a day. Can we simplify those regimens? Or can we make it easier for them to access medications from the pharmacy? So if we think one by one through the causes of non-adherence, I think we can come up with a series of strategies that could be broadly applied to patients.
Now, given that there was no cost to the employer and the insurance company, it was a net wash there. You've described this as being very easy to put out. Yep. What are going to be the obstacles? What do we need to do going forward?
So I think the big thing is just developing the information systems to do this. Now, as it turns out, most of those are already existing systems. There are claims processing systems. Every major insurer has the ability to do this. You know, there has to be a mechanism of contacting patients to let them know. But again, we sent a simple letter and a very simple phone call. And so it's just putting together some of the logistical things. But this is a very low barrier. This can be done completely remotely. This is not like deploying nurses into the field or pharmacists into the field to help patients. This could be done tomorrow by many large insurers.
Thank you, Doctor. Appreciate your time. From the American Heart Association, Patrice Wendling.